Pneumothorax.
Tension, pneumo, tension, hemo. On their own, just pneumo, hemo are not life-threatening. Okay.
Flail chest.
Flail chest, yes.
What else? What else? What do I have in mind? Pulmonary contusion.
Yes, if it's a significant pulmonary contusion, yes. What else?
Pericardial effusion or
Pericardial effusion is the same thing as cardiac tamponade, because it's not life-threatening until it becomes tamponade. So you have aortic transection.
triple A. Okay.
Triple A on its own is an aneurysm. It's fine, and we're talking about trauma. So aortic dissection or transection, traumatic. Open pneumothorax, because it can be transferred into a tension very quickly. The rest of them you guys mentioned, which is good. The only one that may be missing is cardiac contusion. So if you have a blunt trauma to the heart itself, you can have cardiac rhythm abnormalities that can lead to death on its own. Okay, so what's the physiological consequences of these chest injuries?
Hemodynamic instability. Yeah?
Through what? So hypoxia and hypoventilation that lead to acidosis and inadequate tissue perfusion. Yes. Okay, so what are some of the indicators of thoracic injury? We have tachypnea, respiratory distress, hypoxia, which is important in the B part of the primary survey. Remember when we said we measure the respiratory rate, we see if the patient has a normal saturation, if they're in respiratory distress, if they have any tracheal deviation, if they have any abnormal breath sounds on auscultation, if they have any percussion abnormalities, especially if we suspect through auscultation that there is decreased air entry. Percussion may help us to identify if this is more on the side of hemo or pneumothorax. Obviously, nowadays we have ultrasound, which can help us as well. Chest wall deformities. Okay, so any chest wall deformities such as flail chest, let's say. Okay. So laryngeotracheal injuries. These are life-threatening injuries that can lead to airway obstruction. It's rare, but it presents with hoarseness, subcutaneous emphysema, has to be managed in the primary survey as soon as possible. You want to intubate these patients, but you have to intubate them very cautiously. Typically, they're managed with tracheostomies distal to the injury site. So can you see الكرسر حقي الحين أنا وأنا أشر على الصورة ولا لا؟ Okay, good. So typically, this is the line of the injury itself. So if you have the larynx is right here, and you have a fracture in the larynx right here, or you have a laryngeal transection, the issue is you can't have any airflow continuous through the larynx anymore. And number two, if you want to intubate, then it's not a continuous organ anymore. So typically, if you have to intubate, you'll have some struggle going through this area if it's transected or fractured with the endotracheal tube. This is why it's very important, and you have to do it cautiously. So you don't want to give these patients any medication to stop their breathing unless you absolutely have every single piece of equipment or they're dying. The second part is if they want to do a tracheostomy, it has to be distal to the site of the injury, because up here it's the same thing. There's no benefit of it. I hope that's clear. Tension pneumothorax, as you can see on this beautiful x-ray. This is the lung. This is all air. This black area is all air. So should not be something that you diagnose with a chest x-ray. Presents with respiratory distress, can present with shock, distended neck veins. You have absent breath sounds, hyperresonance on percussion, elevated hemithorax, meaning that you have this hemithorax, which is the half elevated compared to the right, just because of the pressure of the air it pushes the diaphragm down. You have cyanosis, which is a late sign. How do we manage this? I have attention to pneumothorax right now. How do I manage it?
Just you.
That's the definitive treatment. But before that, we have to do the needle decompression. So needle decompression, just to hopefully get rid of some of the pressure, get rid of some of the shock if the shock is present, and then you put in a chest tube. Because you won't be able to put in chest tube as fast as you do the needle decompression. This is an open pneumothorax. So what's the mechanism? It's ineffective ventilation. This is why you get the injuries related to it. What happens with the open pneumothorax is every time the patient breathes in, air comes in. But every time the patient breathes out, so exhales, air doesn't come out. So how do you actually fix this? Definitive is operative, but how do you do it? You can put in a chest tube like these guys did. Also, what you can do, which is preferably the first step of action, is you put in a 3-sided wound dressing. Why 3 sides? Because then every time the patient breathes in, the wound is actually covered. But every time the patient breathes out and any air wants to come out of the wound itself, then it can come out through the 4th wound dressing side that can actually allow for air to come out. Okay, flail chest. What's the definition of flail chest? Good, shukran Ahmed. So it's basically 3 consecutive rib fractures from 2 sides. So meaning the same 3 ribs have consecutive 3 ribs have two fractures from 2 sides. It makes it a flail segment. How do you see it on examination? It's a flail segment with paradoxical breathing, meaning that the patient, when they actually inspirate, so the patient takes a deep breath in, the chest wall expands, you see this flail segment go in. And then when the patient breathes out and you let loose of the air from the thoracic cavity, so you exhale, the chest cavity gets smaller, the ribs all go in towards your chest, but the flail segment comes out. So it's basically a paradoxical movement. How do you treat these patients? These patients have 2 major issues. One is that they have a lot of pain, so they splint when they breathe, meaning that they take small breaths, meaning they can't fully inhale because of the pain. And then the other the other issue is that they breathe fast to compensate for the small breaths, so they get tired fast. So you intubate them early as needed. You give them oxygen, give them fluids, you give them pain medication, and then if needed, some of these patients will have them fixed by orthopedics in the emergent, or thoracic surgeon in the OR. And this is just the explanation of the paradoxical movement. Okay, pulmonary contusion. So you cannot really tell what's a pulmonary contusion versus a hemothorax, but the good thing to tell you initially is that, one, if it's a hemothorax, it'll show on the x-ray early. If it's a pulmonary contusion, typically it doesn't show on the x-ray early. It's a delayed finding because it takes time for the injured portion of the lung to actually show as a whitening, like in the x-ray here. It takes time to actually show on the x-ray. So if it shows early when the patient first comes in after the trauma, depending on what time the trauma happened before they present it to you, if it shows like this, typically it's a It's a hemothorax. This is actually a hemothorax because there's a chest tube that's inserted. But just to give you an indication of what a contusion looks like, depending on the time and depending on the symptoms. Same thing, you intubate as indicated for pulmonary contusion. You give them oxygen, fluids, and analgesia for any pain. Massive hemothorax. What's the definition of massive hemothorax? Definition يا اخوان. لا. لا, definition is not blood in the pleura ولا total lung collapse. لا. I want the definition of massive hemothorax. Massive. Yes, so we have blood drainage above 1.5 liters or 1500 ml on the chest tube output immediately. So let's say I have a patient who has a hemothorax. I put in a chest tube, 1.5 liters come out, then that's a definition of massive hemothorax. Or you have more than third the blood volume. So let's say 1.5 liters in a child that has a total blood volume of 4 liters is not going to be the same. So above a third of the blood volume, or 200 ml per hour for 3 to 4 hours. يعني مو immediately يطلع لك 1500 ملي، لا 200 ملي لمدة 3 ل 4 ساعات. 200 ملي لكل ساعة. Continuous. Okay, that's the definition of massive. So you have no breath sounds on examination. You have dullness on percussion as opposed to hyperresonance on percussion when you're dealing with the pneumothorax. You have flat neck veins. Patient comes in with shock, especially with a massive hemothorax. Chest tube, you can auto-transfuse the patient, meaning that whatever blood comes out through the chest tube, you actually filtrate it and reinfuse it to the patient. And then thoracotomy to actually fix the bleeding site by a thoracic surgeon. This is the management for it. Next is cardiac tamponade. What's the triad for cardiac tamponade? Okay, shock or hypotension. Distended neck veins. Muffled heart sounds. Good. Okay. How can we diagnose cardiac tamponade? We have 3 mechanisms. We have chest X-ray, we have FAST, and
echocardiography is the gold
yes,
standard.
Echo is the FAST. Yes. What else? One more.
ECG. Oh.
ECG. What does the ECG show? I'll show you the ECG in a second. How do you manage the, yes, it shows alternans. How do you manage the, how do you manage cardiac tamponade? Not thoracocentesis, pericardiocentesis. Thoracocentesis for the chest. So pericardiocentesis, resuscitation, and operative repair. Good. Okay, so this is what it looks like on the chest X-ray. This is what they call the globular heart, meaning it looks like a globe. It's very large, it's round. And then this is what it looks like on the echo. طبعا on the echo or on the fast, you have to understand that the amount of fluid accumulated in the pericardium does not equate to how severe the actual cardiac tamponade is. Because in trauma patients, as little as 100 ml can cause pericardial tamponade or cardiac tamponade, because it's based on the rate of how much the rate of the fluid accumulation and not the amount of fluid itself. So in trauma patients and otherwise healthy patients that have a sudden gush of 100 ml of blood around the pericardium, around the heart, in the pericardium, that can cause tamponade. However, in cancer patients that have a slow trickle of fluid that lead to an effusion can even sometimes get up to 500 mLs and still not have tamponade, just because the rate is much slower. So the heart can actually compensate for it. But when it's a sudden compression by 100 ml, because the rapid accumulation, that can lead to tamponade quicker. Okay. This is what you guys mentioned, which is alternans. What does alternans mean? You can see just by looking at the height, up, down, up, down, up, down. So that's alternans. This is pathognomonic for the cardiac tamponade.
What
Why?
the low voltage?
Esh?
Low voltage. Yeah.
Yeah, but this is pathognomonic. Low voltage can be caused by a lot of things, but yes, low voltage is one of the signs. But this is pathognomonic, meaning that this is specific for cardiac tamponade, is when you have alternans. Why does alternans happen? Because with each beat, the heart actually swings in the fluid surrounding the heart. So it goes up and down. Okay? Okay. Esophageal rupture. Esophageal rupture, very difficult diagnosis, not very easy to diagnose clinically. Typically is a delayed diagnosis, but presents with shock, hypotension not responding to fluid resuscitation, hypotension not responding to chest tube drainage, hypotension inconsistent with any of the injuries that you see, and the patient has persistent acidosis. Sorry, where is this? Right. You can diagnose with the contrast studies. You can see pneumomediastinum. So I don't think it's showing. Yeah, it's not showing. Anyways, you can see pneumomediastinum. You have unexplained pain, unexplained shock. The diagnosis is with water-soluble contrast studies and endoscopy, and then it's repaired operatively. So this is aortic transection, presents the same way as esophageal rupture, unfortunately. Management is operative repair and resuscitation. Same thing applies for traumatic aortic dissection. But I want to know from you guys, what are some of the signs of aortic dissection on the chest X-ray?
Widening mediastinum.
So that's the most common abnormality, but the most common finding is a normal chest X-ray. Okay, what else? On chest X-ray, Abdulaziz. So you can have multiple rib fractures, deviation of a nasogastric or OG to the right, deviation of endotracheal tube to the right, deviation of the trachea to the right. Because of the pressure here, you can have a depressed left mainstem bronchus. So where the mainstem is, you can have a depressed left mainstem bronchus. And then widened mediastinum is the most common one. Okay, bronchial injuries. So what's an indication for bronchial injury? You can have persistent pneumothorax and ongoing hypoxia despite drainage with a chest tube. This is fixed with surgery. Cardiac contusion, we mentioned what this is basically it can cause arrhythmia. It can cause an elevation in the cardiac enzymes. Typically, if you have a normal ECG and normal cardiac enzymes on the patient presentation, then that's excluded, at least for a clinically significant cardiac contusion. How do we manage? We consult cardiology, and they have to have continuous cardiac monitoring, serial enzymes, maybe valvular repair if needed. What's this procedure? It's called an ED thoracotomy. It has significant special indications to do an ED thoracotomy. It's not an easy procedure. So this is done in the emergency department. You incise all across the fourth or fifth space, all the way until the mid-axillary line. And then you insert the rib spreader and then open it up. And then the idea for this is to, one, if the patient has a penetrating cardiac injury, then you can actually repair it in the emergency department. You can place a Foley in, you can do digital pressure, you can release a pericardial tamponade or a cardiac tamponade. So you release the pericardium itself to allow for the fluid to come out. You can drain any hemo or pneumothorax on the left side. If it's on the right side, or you do a clamshell, then you can see that you can put pressure on the aorta, allowing for proximal flow, especially to the brain, stopping distal bleeding. You can do what's called a quote-unquote hilar twist, where you twist the hilum of the lung if the patient has a significant injury to their lung that's causing bleeding, that's leading to hypovolemia. So a lot of things can be done through the ED. You can do a cardiac massage if the patient's in cardiac arrest, but it has specific indications. So what are these indications? Penetrating trauma indications and blunt trauma indications. So penetrating trauma, if you have any arrest at any time with initial signs of life in the field, meaning at the place of the accident. Systolic blood pressure less than 50 after fluid recess, severe shock with clinical signs of tamponade. These are the textbook indications for an ED thoracotomy. Indications in blunt trauma include cardiac arrest in the emergency department. And then other miscellaneous ones is if a patient has suspected air embolus, which typically we don't see. It typically happens with obstetrics and maybe femur fractures if it's not a fat embolism, but these are all rare circumstances. So what does it accomplish? We went through this. You can do open cardiac massage. You can do open or internal defibrillation, drainage of tamponade, open heart wound management, drainage of hemothorax, drainage of pneumothorax, the pulmonary hilar twist, and then the aorta cross clamp. Diaphragmatic injuries. So you can see clearly on the left side that there's an elevated hemidiaphragm that tells you that this is basically what it looks like is air under the diaphragm, and the gastric bubble is here, so the diaphragm is definitely injured. So it's most often left-sided. It's usually larger tears with blood trauma and smaller tears with penetrating trauma. Symptomatic management, and then operative repair by the surgeons. Now we'll go back to the case. So what injuries do you expect in this patient and why? Okay, so you can have a laryngeotracheal injury because of the belt. Good. So basically, really, this is an unrestrained, high-speed frontal impact MVC. You can have any of the injuries we just mentioned just because the patient is unrestrained, so unlikely to have seatbelt injuries, but can be thrown in or outside of the vehicle. So you can expect any injuries with this patient. But since we're specifically talking about the thoracic life-threatening injuries, then this person can have any of the injuries. They can hit the seatbelt and have a flail chest. They can have significant accelerating, decelerating injury, and then have an aortic transection or trisection or a dissection. They can have hit the steering wheel and have a pericardial tamponade or have a cardiac contusion. So there are significant injuries that this patient can have that are related to the chest, just because they're unrestrained and they may hit the steering wheel, the dashboard, or be thrown out. Conclusion, thoracic injuries are common. Most of them can be identified on the primary survey. The goal is to treat the injuries, establish normal gas exchange, and to get normal hemodynamics as for any of the trauma patients. Any questions about this?
Yes, I got a question.
Fadal.
Earlier, we have spoken already about the needle decompression. As per the guidelines of ATLS, where should be the needle placed? At which level of the intercostal space should be placed?
You tell me. Because you should for the ATLS. انتم السنه الجايه interns صح؟ يعني هالسنه for needle so second that's the بعدل 3 minutes بما اننا on time now. 1 2 3 تمام. يعطيكم العافية. خلاص الوعد بالضبط الساعة 10. Take 15 minutes, get yourself a coffee. We'll see you in 15 minutes.